This is LiveWell Talk on how ER teams respond to heart attacks and strokes. I'm Dr. Dustin Arnold, Chief Medical Officer at Union Point Health, St. Luke's Hospital. Joining me today is St. Luke's Emergency Room Medical Director, Dr. Ryan Sundermann, and ER Clinical Pharmacy Specialist, Cari Batcheler, to discuss how rapid coordination and life-saving treatments come together when every second counts. Dr. Sundermann, Cari, welcome.
Thanks.
Thank you for having us.
It's nice to have you here. So when we hear time is muscle, time is brain. So could you just give an overview when it comes to strokes and heart attacks, why time is so important?
Yeah. So the reason that's important is because blood carries oxygen. The simplest way to think of it is blood carries oxygen. And if that blood vessel is blocked for any reason, whatever's downstream in that vessel is no longer getting oxygen. And all of your tissues rely on oxygen to perform their functions. So heart attack and stroke are very similar. It's just two different organs, a heart being, heart attack, obviously a heart, and a stroke being a brain. But the mechanism in general, when we talk about ischemic strokes or when a blood vessel is blocked, that blood vessel gets blocked and doesn't deliver the oxygen downstream. And so in heart attacks, that muscle starts to die, and then in strokes, that brain starts to die. It takes a certain amount of time, but that process, the longer it's going on, the less oxygen there is, and the worse the damage is.
What do you do in the ER to be more efficient with your time when these patients present? How does that work?
Yeah, well, we definitely have a kind of a swarm approach or a team approach, and so it's kind of an all hands on deck type of situation. That's why we're lucky to have Cari and the rest of our clinical pharmacists there, because they have a unique skill set in that they are very adept, and their background is in medications. And so one of the key things if somebody is having a stroke or a heart attack is to get a vessel open. And a key piece of that is some of the medications that we give. In heart attacks case, Cari can talk a little bit about that. Mm-hmm. Ultimately, we want to get them, in most cases, up to our cardiac cath lab where they can run a special device down and open that vessel up. But in heart attacks, we don't quite have that luxury, and so we have to use primarily medications only.
In strokes.
In strokes, yeah. We have to use medications only. There are a few scenarios where that's not true, but in the broadest sense, we got to get that open with medications.
Mm-hmm.
So, Cari, what are those medications that are used?
So there's a couple different medications that we primarily use for clot-based strokes, or ischemic strokes, as we call them. So we here at our hospital use TNK or tenecteplase. Other facilities might use a similar medication called Alteplase or TPA. Both of those medications are clot-busting medications that go in and help to break up any clot that may be impeding the blood flow to the brain.
They're risky medications, mm-hmm. correct?
Yep.
What are the risks of using these medications?
Absolutely. So these medications, because they break up clots, they come with a pretty high risk of bleeding. So we choose our patients very carefully. There's a list of contraindications to these medications, and we evaluate those for each patient to make sure that they have no contraindications so that we can decrease that risk of major bleeding.
Now, the window for, let's just talk about strokes, mm-hmm. used to be 4 hours, then it was extended to 6. Where's it at now?
Well, it can be all the way out to 24 even, and sometimes even longer in some experimental things. We coordinate with the University of Iowa for some special procedures where they can actually use a similar device to what they use in heart attacks, where they can actually use a catheter, or what that means is essentially a catheter is just a tube that you can administer something through. So it's like a straw essentially, and they run that through a blood vessel, and then it travels up into your brain, and they can identify a vessel that is there. And so the problem is that because of the risk of the bleeding from the TNK and medications like that as the tissue gets less and less oxygen and gets more and more damage, it's more and more fragile, and so it can bleed easier. So the longer you go without having good blood flow to that brain, the more fragile that tissue gets. And so when you give that TNK, it's at risk of bleeding even more than if at 30 minutes, you have a lot less risk than if you're at 6 hours. So, and the other thing is that medication is given systemically, meaning it's given through an IV, so it's all over your body, not just in your brain. And so you can have risks of bleeding not just in your brain, but like your gums, and we often see patients bleed into their bladders and through their IVs. So we coordinate with the university very tightly so that we, for the right patient, and it's a smaller subset of these stroke patients, but we can send them down, and they can run a catheter up and administer some of that medication just in the blocked vessel, and they can free it up, so it takes away some of that additional bleeding risk. So that's because they've been able to do that, and we've been able to share those protocols. that's we can get them down there if it's appropriate, and that's why we have a helicopter, and we have these rapid transport mechanisms to get there ASAP.
Because although there's a risk of bleeding, there's also a risk of disability if the stroke continues to evolve.
Yeah.
And perhaps even death. So.
Yeah, it's definitely risk versus benefit. And, we have to have that discussion with the patients and their families about that. We have to say, there is a real risk, as high as like 5 or 6%, I think, is a bleeding risk. And again, the further you get into the stroke.
It's 100% if you're the patient that it
happens. Yeah, right. Yeah. So there's a fairly high risk, but the thing is that you're facing, and so we don't, if somebody comes in with milder symptoms, a lot of times we don't give it. Like maybe they had just a little subtle facial droop and then it's resolving. A lot of times we might hold off. It's case by case, obviously, but if somebody comes in with pretty profound deficits, meaning that they have like severe facial droop, can't speak, can't see, the whole arm doesn't work, that's something that they would have to live with for the rest of their life. And that is a discussion that we have to have with the family about what their wishes would be and whether or not they are comfortable with that small risk of bleeding. But the thing is that your best chance of returning to your baseline function is if you get that medication.
Yeah. And my years of practice, I found that patients the thought of disability is more worrisome them than death.
Yeah.
People just don't want to be dependent on others. And for understandable reasons.
I'd say, just to put the population at ease, I would say most people decide to receive the medication if it's appropriate, and a much smaller subset choose not to have it. And so sometimes they're having a hard time maybe sometimes knowing that what would most people do helps make a decision, and most people would choose to have the medication, assuming that we've gone over all the risks and make sure that you haven't had any procedures or anything that would add any additional risks. So.
And I would say of clinicians, 100% would recommend the medication for themselves or their family members, because we've seen that.
We see the long-term effects of strokes.
Absolutely. Yeah, devastating. Well, we've talked about heart attacks of the brain. Let's talk about heart attacks. What happens? Take me through like a cath lab alert.
Sure. You want? Go ahead, Cari.
I can start.
Yeah.
So the patient arrives to the emergency department. They typically present with chest pain, but they can have some other symptoms that we can talk about a little bit later. So they present with chest pain. The first thing that we prioritize in those patients is getting an EKG. So our nursing staff is phenomenal at recognizing when a patient might be having a heart attack. They get those EKGs done very quickly, ideally within the first 10 minutes of patient arrival to the emergency department. They bring that EKG to a physician who activates the cath lab if they feel that it's appropriate, if they meet the criteria for a heart attack based on that EKG. And then we do a whole bunch of things, as Dr. Sundermann mentioned. It's kind of a swarm effect at that point. Once the cath lab alert is activated, we all kind of swarm the patient. Nurses are getting an nurses are getting an IV started. They're hooking the patient up to the monitor. We're administering certain medications that we like to get in prior to cath lab, like aspirin, sometimes ticagrelor, clopidogrel, heparin. And then we're coordinating with our cardiology team to get that patient up to the cath lab as soon as possible.
So one of the things I know we talk about and we pride ourselves on is our door arrival to balloon time in the cath lab. What are our times at, and how's that compare to the national standards?
So we do well. We're in, I think, good question. I don't know if I looked up our most recent, but we're always like top in the state for sure. And obviously and it used to be when I started 20 years ago here, we were happy if we were getting there even close to an hour. It was about 90 minutes is what our target was. And then probably 10 years ago, we started shooting for under 60 minutes, and now we're shooting for 45 minutes or under 45 minutes. And that's door to getting the vessel open. And so that's when they run a wire typically now in your wrist. When Dustin and I were doing this a while ago, they'd typically go in through a big vessel in your vein. But these catheters are so well made and so small now, they can typically go in your wrist in a vessel right down by your hand, and they run that wire up. And so the door to dilation time is when they actually achieve blood flow back through that vessel. And so those times, I think we're well above 50% of our patients are getting door to dilation under 45 minutes now. So, but it's a hustle, that's for sure.
How often, there's a time where we use, prior to the Denmark study, we'd use TPA for heart attacks. Does that happen anymore?
Yeah, I mean, rarely. It kind of
Very
depends.
rarely.
Not so much here
Mm-hmm.
and in certain situations, but some of our smaller hospitals will use it. I don't know if you've had much experience with that.
A few years ago, I think we had incidents where there was a patient at one of our critical access hospitals that was there during a snowstorm and there was no transport available. So I think we did do Alteplase for a heart attack patient a couple years ago. But ideally, we get the patient up to the cath lab and we use the clot busting medications and heart attacks less often.
And that's not a bad option. I mean, if you do have a loved one that's in, maybe 90 minutes, 2 hours, and then during COVID, we had a lot of delays in patients getting because the hospitals were so full. But yeah, if there's a snowstorm or something, it's definitely an option. It's not a bad option. And the risk of bleeding elsewhere, as opposed to a stroke, that when you have a stroke, that tissue is so damaged that it's just so much more likely to bleed into that damaged brain area. It's less so in the heart. You still get some bleeding that you can see through IVs and things like that is a little bit unaccepted, but there's still a risk in it. But it's definitely worth it. Like if you have a family member and you're faced with that decision, I'd definitely recommend it if there's going to be any delay in care. And they can still do the cardiac cath, so they used to call it a drip and ship. And so they used to do that pretty routinely. Like we'd start that TPA or TNK, and then if it was a long transport time by ground or whatever, by ambulance, if like a helicopter wasn't available, they would start that medication just to get that vessel open as soon as possible, and then they could still do the cath. There's obviously more bleeding when the cardiologist does the cardiac catheterization, but it's worth it, it definitely, because you got to get that vessel open.
You talked about the EKG determining the next clinical decision to be made. For strokes, how's that clinical decision made?
So there's a couple of different ways. We use a couple of standardized scores. The most widely used kind of stroke evaluation is called an NIH scale. And there's a very long list of things that includes everything from facial droop vision, hand and arm movement, coordination, speech, things like that. And we run through that on all patients. But when they come through the front door, we are really just doing. There's a couple of them. There's a BFAST one that we recommend that the public use, but we use something very similar to that called a VAN score. And that's really just like you're doing a very basic evaluation of that patient. You're checking to see whether they can talk, whether they can see, and whether they can move their arms, essentially, is what you're doing. There's another portion of it that you're evaluating them for something called neglect, which is just kind of a very subtle thing, but it can suggest that a larger vessel is broken. It's basically simply saying it's like if you were to stand in front of a patient, they could see you and recognize you're there. If you're on one side, they know somebody's there, but if you go to this side, even though they can see you, they don't recognize it. That's called neglect, and that can be a subtle thing, and so we don't expect the public to be able to screen for that. But when they come in and we screen them, and that's the other thing is when we get an alert, if they come in through the front door by a private vehicle, our nurses are kind of doing a lot of that initial screening, and they'll call a stroke alert, and then they run and we announce it overhead, and everybody goes to that room, and everybody's in that room instantly. We often, if they're coming in by ambulance, and that's why we recommend to the public that they call the ambulance, because these paramedics know what to call and what to do. They actually, when they come in through the ambulance, they don't even go to a room. We meet them at the ambulance bay. And because if they tell us that they're confident it's a stroke, even if it's not a stroke, we want them calling us so that we can meet them at the door. And in almost all cases, and the paramedics are fantastic in all of our surrounding communities, and especially with area ambulance, Hiawatha, Marion, they all do a phenomenal job. And they come through the door, and we evaluate them right there outside of the ambulance bay. And then we take them our elevator up to the CT scanners right there. So we pop them right in. We go there. We often accompany them there. And I'm calling the neurologist on the phone as the patient's getting loaded up onto the CT scanner. So this is a lot of stuff happening simultaneously, just to kind of really expedite that.
So the CT scan is the EKG of the brain, basically.
Yeah. So the EKG initially really is our screening, and is just like kind of going through that checklist. And then the CT scan is kind of confirming, but more than anything, and in fact, the CT scan often doesn't even identify the stroke, and that's what some patients, or sometimes they assume, that we tell them that the CT scan looks okay, but what we're really looking for there, because if we can see the stroke on that CT scan, then generally it's a pretty big one. What we're really looking for is, are they bleeding? Because if I evaluate that patient and they're clearly having a stroke to me based on my clinical findings, and then what I want to know is there any bleeding? Because there are bleeding strokes that can present just like a regular blockage stroke or these ischemic strokes. And so we just need to make sure that that's not bleeding, because we cannot give TNK to those bleeding patients, because clearly they'd make that much worse. So as long as we can confirm they're not bleeding, then they come down and they get the medication. And ultimately, our final diagnosis is usually based on the MRI that they do kind of the following day. And that just kind of confirms where it is and how big it is and things like that. So.
Because someone could have a brain tumor,
Yeah,
right? I mean,
yeah.
present similar.
Seizures, I mean, low blood sugars. I mean, so that's a nice thing about the paramedics. Somebody comes in with a stroke, they've already done the blood sugar, they've already done, so we know these guys have already screened them for kind of some of the other things. So it's nice to
It wasn't always like that.
Nope.
I mean,
Yeah.
So if we try to get the EKG done for a heart attack in 10 minutes, how soon do we try to get them in the scanner, Ryan?
And fast. We want that head CT read within less than 30 minutes. But I mean, even 30 minutes, we even have a special phrase that we put on our head CT. We use a stroke order set, which means it's a whole bunch of stuff that I can kind of click one button and it orders all that simultaneously. But and so that it shows up as a stroke head CT, which prioritizes it. But then we even put on the note in there, we say, this patient is a TNK candidate. Because sometimes they come in and they might be, we're like, this might be a stroke, but it's small, it's subtle. We're like, I don't know that TNK is the right answer for this guy. But if the clock's ticking and we want to give that TNK, we put that so the radiologist can see TNK candidate. And so then they call us with that read. But we're all hovering around, we're waiting for that thing to come back anyway. So, everybody's looking. It's pretty redundant because we don't want to have any delays or misses and things like that.
Right.
Mm-hmm.
I think it's good to mention for the public and listeners that we don't, in a like utopian world, we could just get an MRI on everyone, right?
Yeah.
But they take time.
They're long, 20 minutes,
Yeah.
And you don't want to wait. Yeah. And then if the patient has a potential to get worse, it's a better study ultimately. But you got to be careful when you're putting patients in there.
Yeah, definitely. Yeah. You mentioned calling 911 if you have that. Patients will ask me, well, when should I go to the emergency room? So you should go anytime. Let us determine whether or not it's significant, not you.
Yeah.
But really, time is muscle, time is brain, and so the take home to the public is initiate that emergency rescue system to get here quickly. Correct?
Mm-hmm.
I mean,
yeah. I mean, so 911 is there for a reason. And that's the thing is, let us, if you think it's potentially an emergency, assume it's an emergency. Your emergency is our emergency, essentially. And we'd rather have you kind of go way over the top, and then we can de-escalate. And as opposed to, so I tell people when they come in, a lot of times what I tell people is, especially as an emergency physician, my job is to think of the 5 or 6 worst things. One of my old mentors used to tell me that. He said, I want you to start at the very top and work your way back down. You don't have to tell them because you might scare the patient, but your job is to think of those worst things and work your way back from there. Whereas your primary care doctor, you go with them, it's a completely different environment. You're like, hey, I've had this little back pain for the last 3 days. He's like, oh, it's probably muscle strain, all the common things. But if somebody comes into me and they're like, I have this horrible back pain that started 1 hour ago, I'm going over to kidney stone and aortic dissection, and I got to think that. Doesn't mean I have to go after it. So that's the thing is if you think it's an emergency, let us help you make that decision, and we'll start at the top and work our way backwards from there. Just to give you, so we don't have any delays. Make sure you get it taken care of. Never feel silly for coming in. Patients say to me all the time, oh, I'm sorry if I wasted your time. That is never the case. I don't care what the complaint is, right? Because it's not a problem. What you don't want to do is not go in and then regret not coming in. So.
And also, I think it would be appropriate to mention at this time that, if you come to the emergency room for a concern that's urgent, perhaps not emergent, needs to be addressed, that some of these patients come in with these other conditions may bump you down a little bit on the list. Mm-hmm. And so if you're waiting for a period of time, I think it's important for people to understand that. We don't want you to wait. We'd prefer you didn't wait. But sometimes emergencies come in that are of higher priority.
That's the triage process that we do, and that's going to be very frustrating for somebody if
they
do have some back pain or they sprain their ankle real bad
totally
or something. They're sitting there, but then somebody's coming through, and the thing is, it's not like they're announcing overhead what that person's complaint is, so you really don't know. And you see 3 people go in front of you after you were there before them. That can be frustrating. That's certainly understandable, and we try to communicate that message.
No, you guys do a great job of being transparent about where the patients are at.
I think with all the TV shows out there now, I think they're starting to get the idea, like, oh, yeah, crazy stuff comes in when I'm just sitting, watching from the window over there. So,
Speaking of TV shows, you watch Pitt?
I've watched the first series. It's written by emergency doctors. And so the first couple of episodes, I was like, these guys seem to have a lot of inside knowledge compared to all the other shows that came before that. And one of the things that I use in a podcast I listen to is the physicians that actually write it. And they're fantastic. And so watching it, I was like, I got to quit watching. This is like watching myself work. They compress a lot into that time.
Yeah, they do.
But it's good to watch them include a lot of the other like social issues that occur in the emergency department, because we really are the safety net for a lot of the population. Or in the middle of the night when nobody else is open. You know, I kind of tell people sometimes, I'm like, we're like Walmart. We never close, even on the holidays. You know, we're always here. And so, you know, it's a good show. I think it represents very much an inner city feel. I did my training in Detroit. I think you worked in Detroit too, and definitely kind of a different environment in an inner city situation. But all the same problems are the same for all humans. You know, and that kind of, it's cool that it brings light to we all suffer and we all get sick in the same ways, and we all heal in the same ways. And so it's
I think they've done a good job of highlighting some of those bed availabilities that we deal with every day.
Hospital problems.
You know, I think it's cyber attack. You know, I mean, I think they've hit a lot of stuff that people don't typically think that we have to think about, but we do. Uninsured patients. We give them the same care we give everyone else.
I have no idea what your insurance is when you come here, and nor do I care. That's what that's why I do the job. Is
absolutely. Because
I'm going to take care of everybody the same, no matter what they got going on. So
Kira, are you a little upset that Pitt doesn't feature clinical pharmacists like they should?
Why don't they?
You know what? I don't watch the show myself because, again, I don't want to feel like I'm at work when I'm not at work. But I think there was a clinical pharmacist
actually
featured
think there was
recently. Actually, I think we got our little moment in the spotlight. So I appreciate them including the interdisciplinary team.
Yeah.
Well, you know, we've had multiple podcasts about heart disease and prevention, one recently with some of our cardiology colleagues. What about stroke prevention, Cari? What would be the recommendation from your clinical training and experience to prevent strokes?
Yeah, so it's actually very similar. Preventing strokes is to preventing heart attacks. Some of the same risk factors apply to strokes as they do to heart attacks. So one big thing is controlling your blood pressure. So if you have elevated blood pressure, make sure you're taking your blood pressure medications, make sure you're watching your diet. Secondly, we want to control your lipids in your blood, your fats in your blood. So if you have hyperlipidemia or high cholesterol, make sure you're taking your statin medication or any other lipid lowering medications that are prescribed. If you're diabetic, watching your blood glucose is important, making sure your blood sugars are in check. And then getting regular exercise as well is very important in preventing strokes and heart attacks. So some of the
similar recommendations.
Yeah, some of the risk factors are very similar between the two disease states.
Well, Dr. Sundermann and Cari, I want to thank you so much for joining me. This has been great information. Once again, this was St. Luke's ER physician Ryan Sundermann and medical director, and ER clinical pharmacy specialist Cari Batcheler. For more information on emergency care, symptoms of heart attacks and strokes, and more, visit unipoint.org. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe, and if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.